Hello, everyone. Welcome on behalf of the National Latino Behavioral Health Association and the Addiction Technology Transfer Center Network. We welcome you to this webinar that was first recorded in Spanish and entitled Providing Culturally Sensitive Trauma-Informed Care. My name is Fabricia Prado. I am a Brazilian psychologist and a clinical social worker licensed in the state of Georgia in the United States. I will present to you the translated version to this web conference that was originally organized in Spanish and hosted by Dr. Pierluigi Mancini, Director of the National Hispanic and Latino Prevention Technology Transfer Center Network. Before I introduce you to today's webinar, to the presenter, here is some housekeeping. This webinar will be archived for future reproduction. It is also being recorded in Portuguese. A copy of today's presentation will be available after the webinar for those who requested, and will be online in the ATTC website. At the end of the presentation, there will be a question and answer session that was generated in the live presentation in Spanish, and I also translated it to be presented here. There are very interesting questions, and we will provide all the answers given by the presenter during the live webinar. We will also ask you to complete a brief survey at the end of this webinar. This satisfaction survey is important for the work that ATTC does and gives them the opportunity to improve training efforts, even if you do not obtain continuing education credits for this event. They plan to do it for future events. So let's begin. And these words that I'm going to be using from now on are the exact words translated by the host, Dr. Mancini. Allow me to introduce you to the National Latino Behavioral Health and Addictions Association, NALBA. NALBA is a non-profit organization located in New Mexico. The Addiction Technology Transfer Center Network, ATTC, is located in NALBA. NALBA was established to meet the need for a unified national voice for Latino populations in the field of mental health and addictions, and to draw attention to the large disparities that exist in the areas of access, utilization, evidence-based practice, and properly trained staff. The executive director of NALBA is Mr. Freddy Sandoval. This ATTC is part of the ATTC network, which is an international multidisciplinary resource for professionals in the field of addiction treatment and recovery services. Established in 1993 by the Substance Abuse and Mental Health Services Administration, SAMHSA, the ATTC network is comprised of 10 domestic regional centers, 6 international HIV centers funded by PERFAR, 2 national centers of focus areas, and 1 network coordinating office. Together, the network serves all 50 states, the District of Columbia, Puerto Rico, the US Virgin Islands, and the Pacific Islands of Guam, American Samoa, Palau, the Marshall Islands, Micronesia, and the Mariana Islands. The international HIV ATTCs serve Vietnam, Southeast Asia, South Africa, and Ukraine. In this slide, you can see a map of the ATTC of the United States. The Hispanic Latino National ATTC has a national focus for Hispanic and Latino communities and the workforce that provides services to these communities. The Hispanic and Latino ATTC has the following personnel: Dr. Pierluigi Mancini, Project Director, Maxine Henry, Project Co-Director, and Ruth Yanes, the Executive Assistant. The National Latino Behavioral Health Association is also home to our sister TTC, the National Hispanic and Latino Center for the Prevention Technology Transfer Center. We will be providing contact information at the end of this webinar. Our dear presenter today is Dr. Hannah Hernandez. Dr. Hernandez has worked for 31 years in the field of health and human services, developing, implementing, and evaluating culturally and linguistically appropriate prevention, intervention, treatment, and recovery programs for youth and adults. Dr. Hernandez is a professional coach and facilitator and provides individualized technical assistance and support to organizations that provide support for prevention, intervention, treatment, and recovery of addictions. Dr. Hernandez has many years of experience providing clinical advice and supervision on addictions for professionals in the field. He is a person in long-term recovery. He has a personal commitment to eliminate health disparities by focusing on health equity using a social justice lens. And what follows are the exact words of Dr. Hernandez during the live webinar that were translated by me from Spanish to English. Let's begin. Thank you very much, Dr. Mancini, for the opportunity to collaborate. And thank you all for preparing this seminar. As I said, I am a person in long-term recovery. For me, what it means is that I haven't used a drug, including alcohol, in the last 32 years. And that allows me to be a productive member of my family, my community, and to do the kind of work I do every day for the Latino and Hispanic community in the United States. Today, we are talking about the issue of trauma, and I thought it is important to start with a definition at the level of individual trauma. The individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual or physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And this is a definition from SAMHSA. We must always think that trauma affects the person in a holistic way, affects the person in all these parts, the mental, the physical, the social, the emotional, and the spiritual, but also impacts the entire family and communities. In relation to trauma, we must also look at the historical aspect of the trauma and what is called historical trauma, which is an event, a set of events that happens to a group of people who share a specific entity. Think about the Latin community in relation to this definition. That identity could be based in the nationality, tribal affiliation, ethnicity, race, or religious affiliation. Again, I ask you to think about the Hispanic Latino communities in the United States. Events are often carried out with genocide or ethnocide intent and result in annihilation or disruption of traditional forms of life, culture, and/or identity. Each individual event is profoundly traumatic, and when you observe the events, They represent a story of sustained cultural disruption and community destruction. In other words, trauma does not only impact the individual, it impacts the family, it impacts the community. And this includes historical events that have happened years ago and continue to impact our people daily. We're going to talk about 3 categories to conceptualize trauma, and this includes indirect and direct, and insidious. Then let's review those 3. Direct trauma occurs when a person is the target of trauma. Since people experience trauma at the individual level, indirect trauma implies the response of a person to difficult or serious events suffered by another person with whom the person closely identifies. Let's think again about a Latino family when a person from that family or several people from that family have experiences with trauma. There are other people who are affected by it. And then the insidious trauma occurs when individuals are devalued by those in power, and this experience generally persists throughout life and has a cumulative effect. Again, thinking about the Latino communities and all the Latino families in the United States and how there is repression and discrimination and how this impacts trauma processes for our people. And then we talk a little about how we make treatments that are informed by trauma or trauma-informed care. Then an individual, an organization, program, or a system that realizes that widespread impact of trauma and understands potential paths for recovery. In other words, there are several ways that people can improve from these effects of trauma. This also recognizes the signs and symptoms of trauma in clients, families, staff, and other people involved in the system. Note that we mentioned clients and families again, but we include our people. As we work with people from communities and families, we have also been exposed to this secondary trauma, and it is important that we understand this. Trauma-informed care also responds by fully integrating the understanding about trauma into policies, procedures, and practices, and actively seeks to resist re-traumatization. In other words, it is completely incorporated in the public policies of the organizations. And lastly, here the adaptation of principles and practices that promotes a culture of safety, empowerment, and healing. This means that the whole system should be aware of what trauma is and what should and how and what we should respond in a positive way to our people. There are experiences and factors which contribute to trauma in the Hispanic and Latino communities. So we are going to review some of these things. Generally, what we understand about trauma includes verbal abuse, physical, sexual, mental, and spiritual abuse, and so on. I would say that there is a great deal of knowledge in our society that these things exist. But sometimes it is forgotten that poverty also has an impact on trauma, and that having the experience of poverty is a traumatic experience for so many people. Experiences with violence. Recognize that including trauma and violence, we are talking about gender violence. We can also talk about violence in communities, gang violence, police violence. and negative elements within communities, and non-physical violence, as violence can be psychological too. A lot of what has been said today, depending on what you are paying attention to, is about what is happening at a national or regional level regarding immigration and family separation. And this impact is not only traumatic when people come here to the US, it is also traumatic in the process of immigrate, because these processes mean that people have to say goodbye to family members, friends, and entire neighborhoods. And then there is a long and difficult road to reach the United States. And this is traumatic, as you can imagine, after all this, getting to a place where families will be separated, babies, children being apart from their parents, and all that resulting traumatic experiences for both children and adults and all people involved in these processes. Next, we have experiences of homophobia, racism, sexism, and other forms of discrimination that exists in everyday society and is seen in the media. Where people go to seek and receive services, there are many experiences with these forms of discrimination. The use of controlled substances, including alcohol, can have traumatic effects. And imagine a person who injects heroin, for example, 10 to 15 times per day, or inhale cocaine, smoking, alcohol. All these processes may also be traumatic for people within other communities. And a very important area that we should pay more attention to is experiences with criminal justice system, including jails and prisons. There are approximately 2.3 million people in prison in the US, and a large proportion of these people are Latin and Hispanic. And this process of being in jail or prisons are traumatic for our people, as well as not having a home and live on the streets, because within that comes the substance use, hunger, experiences with poverty, all these causing traumatic experiences to our people. And some other causes are, as we have just seen, what happened, for example, when the Hurricane Dorian and what it did in the Caribbean and other parts of the world. Also, Hurricane Maria in Puerto Rico, and what happens to the people who live in this kind of experiences with events that are traumatic. Think of war, think of the kind of violence that exists in our communities, and all of these things contributes to the development of trauma within the Latin and Hispanic communities. And there are a large number of addictional factors that contribute to trauma. And I want you to think of these other factors as well. People who experience chronic, multiple, or repeated trauma, including historical trauma, are more likely to have more pronounced symptoms and consequences, which includes the deterioration of social life. Think about how the social life of Latinos is interrupted when they have experiences with traumas. This includes impacts on education processes and at work. We know that there are people who leave educational processes or who quit their jobs or who are fired from their job because they cannot be consistent. They cannot fulfill their educational or work responsibilities. People can also develop depression, anxiety, and many have and reported having sleeping difficulties. And these negative impacts also affect individuals' relationships, couples, family members, friends, even in working relationships. And there are many people who seek to self-medicate because of things related to their trauma. So this will lead to the use of substances, including alcohol and dependence or addiction for many people. It can also increase self-harming, suicide, and violence. There are many people who hurt themselves and harm their loved ones, the ones around them, and many contemplate taking their lives, and many have taken their lives because they don't understand, they don't know how to deal with what is happening to them in their daily life. There are high risk of physical illnesses and mental disorders. Physical illnesses are aggravated when the person has experienced with trauma. And we know that there is also a large number of mental disorders, such as those mentioned previously, anxiety, depression, and other issues that people experience in these processes. And now, talking a little bit about cultural elements in the families of Latino and Hispanic communities that we must consider as workers, as service providers to those individuals, families, and communities. If you do not have much information about these cultural elements, I suggest you seek more training. Here are some of them. The first one is familism, and this approach is focused on the whole family, in the collective, and not in the individualism that is most commonly promoted in the US. The definition of family can include comadres, compadres, godmothers, godfathers, or buddies of the family, and other people in the communities. Remember that when our people migrate to the United States, maybe not the whole family migrated with them. So what is the definition of family to the Latino families? It is organized around the collective. Another very important cultural element is personalism, since it is the emphasis on relationships that promote compensation with respect and kindness. This includes asking and answering a series of questions that can be somewhat personal. If you work with Latin people, you realize or have already realized that there are people who ask you how many children you have, what country you are from, what you like to eat, and if you're married, how many children you have, what country you are from, and so on. So be aware that personalism is something that our people seek and require in order to connect with one another. And in this way, it's showing to others what respect is. There are many people who have difficulty answering personal questions. And I suggest that people think about how they can answer some questions that are somewhat personal without providing much information, so they can at least demonstrate respect and cultural competence. Respect is promoted according to the position and role within the family, social position, gender, economic status, among others. But our people are always directing their attention to the issue of respect. There is this element of spirituality in religion, and although in the US, many people think that these two must be separated, for Latinos and Hispanics, spirituality and religion often go hand in hand. That is, there is no separation between the two, and it does not mean that it is so for everyone. But for some people, that is true. Although there is respect for science and medicine, The Latin and Hispanic community incorporates diverse religious and spiritual elements in their way of seeing life, in their way of asking for help and solving problems. Even the US Drug Association recognizes those elements of spirituality and religion to be considered in how to treat Latinos. And we have to understand that although there are many people who do not like to talk about spirituality and religion, they are always present in our interactions with the Latino and Hispanic communities. Okay, the next cultural element refers to Marianism. This comes from the interpretation of the Virgin Mary and the expectation that the woman Mary have children and sacrifice for her family. And this question of getting married is not negative per se, but if it becomes an expectation that all women should get married, we see the stress that it can cause in having them sacrifice for their family and their needs coming last. And all that can also be problematic for women. So it is an element that exists within our communities as cultural expectations that creates stress for women, for whole families. If women can exhibit those characteristics of Marianism, men can do it too, and for them it is called machismo. This characteristic makes a significant difference between men and women. Man is recognized as the person of authority in the family and involves some behaviors that are acceptable among men that are not acceptable among women. The father is seen as the provider of the family. And here I want to talk a little about some things that some people may not pay attention to. As a Latino man, as a Puerto Rican man, I was taught that one should not share feelings, that men don't cry, that men should behave in a certain way. And if you think about treatment and how to provide help to people, all this have an impact in men, specifically in how Latino men ask for help and behave in relation to treatment, particularly when it comes to treatment. If it is said that people have to share and overcome their feelings and those kinds of things. But not everything about machismo is bad. The father is seen as the provider for the family. And I repeat, this is very good, being the provider of the family, being the caretaker, the one who protects the family. This is very good. Next, we refer to the element of trust. Trust is a central element that requires time for its development. Understanding, respecting, and incorporating the other cultural elements can contribute to the development of trust. And before our people can talk about difficult issues, they seek to develop trust in a practical way. And this is not by chance. By incorporating all these elements, we will have greater success in the treatment of Hispanic and Latino communities in the US. And now let's focus on resilience and strength. Much has been written and much research exists on resilience. And recently I heard a person who had a lot of experience with trauma talking and defining it this way. Resilience is resistance and power in the face of adversity. Our people have the strength, knowledge, experience, and the ability to improve their health and current situation focusing on what is possible. We have a lot of experience. There are people who tell you that it will be very difficult, or you can't do it. Or, look, this person is completely broken and needs to be restored. If you take the perspective of looking at people from the point of view of deaths, what are we going to have as a result? But if we look at people with their ability and power to improve their lives, then they will improve it. When you use a perspective focused on strengths, it promotes resilience in our people, and they can take control over their lives and communities. How should we deal with the screening and assessment of trauma? So this is the next part. The lack of screening and assessment related to trauma can prevent mental health and substance abuse treatment from being successful. If you don't focus on it, there will be a negative impact on success. The symptoms of unrecognized and untreated traumas can lead to premature termination, a greater risk of relapse, of psychological symptoms, or use of substances, and worse results, since if we do not recognize the symptoms and do not incorporate the trauma into treatment, then the person can drop out even before starting treatment, and there is a higher risk of relapse. Screenings and assessments and evaluations can also prevent misdiagnosis and improper treatment planning. People with a history of trauma often show symptoms that meet the criteria for other disorders. So evaluating and assessing in a competent way is important in order to understand what is happening with our clients. So here are some important considerations related to the screening and assessment of trauma. And here it is suggested that we use only validated instruments for the screening and assessment, although there are people who do not use instruments and can evaluate a person by talking and asking a series of questions. Here, it is suggested that we use instruments that have been validated. Ask all your clients about a possible history of trauma. Use a checklist to increase proper identification of such history, and be careful when asking questions so that we do not get too deep and re-traumatize a person. So it is important to document, because that way we don't have to be asking people the same questions again and again. And we have a lot of that in the system, where the person who does the intake asks people some questions. Then they meet with another person and they ask the same questions. And then the counselor asks a series of more questions. And the person feels like, wow, I have lived this experience of trauma in my life several times. And now they are asking me the same questions and I have to repeat everything. But early in treatment, we must evaluate all clients who have a history of exposure to traumatic events in their lives. And again, in a careful way, not to re-traumatize people. And we should not delay the screening. Do not wait for a period of abstinence or stabilization of symptoms. We should do so immediately, because we want to incorporate all these symptoms related to trauma in the treatment plan. Then we continue with these considerations here. Do not require clients to describe in details those traumatic events, and do not require people to go very deep explaining some things to us. just get enough to incorporate it into the treatment plan. If they confirm traumatic experiences, ask them about suicidal thoughts and behaviors. It is extremely important that at the beginning, the questions are asked and that there is a follow-up in relation to thoughts and behaviors that have to do with suicide. There are many people who attempt suicide and or who actually take their lives in relation to their traumatic experiences. Be aware that some clients will not make the connection between their trauma and their current behavior patterns, such as the use of alcohol and drugs. There are people who have traumas, but they don't understand that they are using alcohol and drugs for that reason. It is important that we pay attention to this fracture between the symptoms and what people are doing to self-medicate. Talk about how you use the findings to plan the client's treatment and discuss any immediate action necessary, such as how to organize interpersonal support, referrals to community agencies, or immediate treatment. And it is extremely important to have collaboration with other organizations and with individuals who provide the type of services, because our agencies sometimes offer the service, but they do not have everything that is necessary. And remember that people need a lot of support and a lot of attention and care. Okay, here in this next slide, you can see a list of some assessment tools for trauma. If you don't have any knowledge about ACEs, the adverse childhood experiences, it is a number of specific questions about adverse childhood experiences. And this is a tool that is used throughout the United States and other countries, and that's very useful. And there you have the link to know more about that. From SAMHSA, tip number 57 is used to screen and access the presence of adverse or traumatic life experiences. And there is a link there. The tip 57 combined with other tips is a very good resource. We suggest that you visit the SAMHSA website and look at tip 57 and others that have to do with cultural considerations. For people with suicidal ideas, there is tip 50, also from SAMHSA, specifically from the Center for Substance Abuse Treatment. And this one is to help with the person who has suicidal tendencies or thoughts in their life. So now talking more about some strategies, additional techniques, and suggestions for our Hispanic and Latino communities. For me, it all begins with our organizations. They must employ staff that speak Spanish and understand the culture of the clients and the impact of trauma. So we must do this in a very specific and organized way. I visit many agencies throughout the United States. And here, where I live and work in Massachusetts, when I come in and ask the person at front desk who claimed to be a Latin person, although I speak English, I immediately switch to Spanish. And I notice that not everyone who is there in the front desk may know one word or another in Spanish, but they are not really bilingual. I speak with counselors, clinicians, with the staff within the organizations, and they either have no staff who speak Spanish Or they have people who speak Spanish, but it's very limited. And this is problematic. So here I emphasize that our people do not only speak Spanish. Our people speak English, but many people speak Portuguese and other languages. So we need to evaluate who is the clientele we have at our community level. Who are the people coming through the door at our agencies? Who are the people we want that come in, that we want them to come, but are not coming? And we must evaluate which languages we are utilizing. And in relation to languages and staff, we are not only referring to the matter of which language is spoken, but also materials and resources that have been produced in Spanish, Portuguese, and other languages that our people can use, and that the staff is knowledgeable about them and knowledgeable about trauma issues. And if they don't know, the question is, what is your agency doing to make sure that employees have the appropriate training? In addition to the appropriate training, we can also discuss clinical supervision and self-care practices. As a trainer throughout the US, I always ask the questions to clinicians who are in the classes, courses, and seminars. I ask how many of them are taking clinical supervision. And sometimes half of the people raise their hands. Sometimes 25% of the people in some groups, 100% of them. Then I ask them questions about their experience with clinical supervision. And some will say, I have a clinical supervisor, but he sees me only sometimes. Or they just ask questions on the hallway, like, how you're doing? Do you have any questions? But this is not clinical supervision. And if people do not have proper clinical supervision, how are we making sure that they are doing their jobs properly? And how do we make sure that they are doing well? Remember that trauma is something that a person who helps others through their traumas can also experience it. We must create a space that is comfortable, safe, and confidential in our agencies. In other words, that people should not be talking in the halls about the issues of trauma and their experiences. It has to be done in a safe and confidential place. We must develop internal policies and develop relationships with organizations that offer culturally appropriate services as referrals to our agencies, even if we have very good services. In many services there are other people who can and should provide the services, and we need to collaborate with them and with these other organizations. We must develop written agreements for collaboration. And remember that there are countless people within our agencies or who come to our agencies who don't have documentation to be in this country legally. So the space must be safe for immigrants and not to re-traumatize them or to be asking questions about legal status in this country. Or people may say, I don't come in here. Or they may say, give me a minute that I need to use the restroom. And they will never come back for fear that they will be reported to immigration, that they will be deported. Remember that not everyone in the United States has documentation and that it is our responsibility to help them in this way. It is a lot of information to be presented in a short time, but this was rather an introduction to the subject and some resources. So now we will start. Here you have the slide for the presenter's contact information and the National Hispanic and Latino ATTC contact information. But I will ask you to wait and continue here with me because we are going to start the Q&A session. After the Q&A session, we have still the evaluation. So there will be a link and you need to click this link to complete an evaluation about this webinar. So I ask you to please stay until the end. And this Q&A session was generated again in the live webinar, and several questions were asked about new topics and new details of this conversation about trauma-informed care. So let's begin. The first question. Someone asked, I work with young Latinos from 13 to 18 years of age in a youth prevention group in Charlotte, North Carolina. Many times we have young people who have good and bad days, and it shows. How can I prevent re-traumatization in the activities we do, especially in group activities, in group conversations? Then, in the words of Dr. Hernandez, this is a very good question. That work with young people is super important. So thank you for your commitment to our youth that needs it so much, and many of them have experiences with trauma, as you may know well. I think young people have a lot of resilience and a lot of strength. I think that the focus on what is possible, on their strength and what they bring is a way to avoid re-traumatizing people. So depending on the type of activity, the type of questions too, if you are working with young people who are young immigrants in this country, you should be careful with the type of questions asked or what kind of activities are done with those young people that has to do with immigration processes, and allow the young people themselves to bring their knowledge, their concerns through questions and those kinds of things. One aspect I understand that is important, it's when one physically notices that the person is not feeling well. There is something that is showing physically, psychologically, in the way they are dressed, in their way of avoiding looking eye contact, in their way of sitting or crossing their hands, things that you can observe. So I think both for young people and adults that the person talks to the other person apart, calls them and say, hey, I'm noticing this, are you okay? Do you want to talk to me individually? Do you want to leave the group for a few moments? Or do you want to walk and talk one-on-one? So in other words, don't force a person to be in the group that if they don't want to be there. And the person may not tell you, I don't want to be here verbally, but they can tell you with these manifestations on a physical level. And that development at the level of personalism, at the individual level, to see the cultural elements with the person before and after the group is extremely important to treat him or her. That would be one of my answers to your question. Next question. Could you give me some tips on how the staff in front of a clinic, like that front desk, can respectfully connect with Latino and Hispanic clients if they are not Latinos, if the staff is not Latino? I think that one does not have to be, I think that a person does not have to be Hispanic or Latino to work with the Latino or Hispanic community. But you must have knowledge about that family, that culture. So those cultural elements that I presented earlier, everyone, including people who are not Latino or Hispanic, should seek a little more training in those, on those cultural elements. So when you have that, you can respond much better to these communities. And notice that I know people who do not speak Spanish, but who know the Hispanic and Latino communities so well because they know those cultural elements about personalism, about the matter of trust, the definition of family, simple questions like, what country are you from? What language do you speak? What brought you here today? What concerns do you have? And when one does those questions in a respectful way, at the individual level, and not pointing out to the people what they have to improve, but by developing trust first, then reaching that point little by little, those conversations can develop. Those people may say, oh, I want to come here. Although this person is not Latin or Hispanic, at least they treated me with respect and dignity. And this is extremely important because we remember that there are Latin and Hispanic people who treat people very badly too. So there are ways to reach those communities. Next question. There are several questions on the topic, but let's ask this one. How can we include the family in this type of care? Because this is one of the cultural elements that has to do with familism. I will return to that subject as such. The definition of family for our people is somewhat different from the traditional family of the United States. So let's start with understanding that it can include the comadres, compadres, godmothers, godfathers, buddies of the family, neighbors, the very close friend, brothers, sisters, close cousins. So the definition is different, it's much broader. For me, it starts with asking the client, who do you consider family? A fairly general conversation. And then ask who, if any of these people, you could include in these conversations. Who would you want to bring here? Because sometimes we think, look, you must bring so-and-so, or you must bring this person. No, that should be a question we ask the client, and that the client is the one who tells us, I want to include this person. Then we must develop a relationship with that person, get the necessary documents signed to protect the confidentiality issue, then make an approach and develop a plan. What is this person going to come for? What are we going to talk about? And what do you feel comfortable talking about? And develop that relationship little by little. Remember that many of our people come to the service sites and come with other people. And that sometimes it's said, who are all those people who come with you? And there are agencies and programs that feel uncomfortable because many people arrive, they're talking a lot in the waiting area, and they come to tell people, look, you can't bring all those people here. That kind of thing. And that's not good because when the person appears with 2 and 3 more people, that means he has a support system. If we care about the issue of security and confidentiality, that we should do it developing a safe place. Then we ask them to sign documents or what is necessary. Then we ask the client, who do you want to incorporate? That is a sign of respect. It is a demonstration of strength and resilience, and a demonstration that we want to help people in their entirety using cultural elements. Another question, could you share your experience with faith-based initiatives and strategies to address trauma and substance use? I return to those cultural elements. Many of the people who come to our agency for service have already been to other places. We are not the first line of defense or the first option for these people with whom we work. Usually, people go to a pastor, a priest, they go to a church person, they go to a healer, they go to a spiritualist, a santero or curandero, according to their cultural, religious, and spiritual beliefs. They first go to those places. In our communities, if you throw yourself in the community and look, there are botanists, there are natural healers, there are churches. And in my experience, when I talk to people and develop that trust through personalism, and I ask them and know them little by little, I ask, who else did you go for help or guidance? And they say, look, I went to the pastor before, or I went to church, I talked with a priest, I talked to that person. And I don't tell them that's bad. I ask them, how did that help you? What did you learn? And what else do you need? Then I incorporate that into treatment. I say, how else are you going to get involved in your church or in these other practices that you have that are helping you and that will help you? So, in other words, we are another support for that person. Because what we must try to understand is how that is helping or not. Because I may not be helping you, but our people will always go to other places to seek help and guidance. And we must understand that and incorporate it into the conversations. And in the United States, it is said that we should not talk about religion or spirituality, but with our people, that is necessary. It is necessary to understand it. And I finish with this part of the answer to the question, which I think it is very good. It is important that we as organizations, as individuals, as therapists, psychologists, psychiatrists, and others have relationships with these people that exist at the community level. Because many of these institutions are working with immigrants. They are working with people of need. And we must make referrals to those places because they have countless services that are useful for our people. But if you don't know where they are and where they exist, which ones are appropriate, which ones are not very safe for our people who have immigration issues, for example, then we won't be able to help our people in a competent way. Next question. Is it important that the provider be the same sex as the client in trauma-informed care? Then Dr. Hernandez says, for some people it is, but not for others. It is like everything else. Someone is going to do some kind of interview, like a series of initial interviews with the person when they arrive at the agency. And usually that person in some organizations or agencies is not the same person who is going to be the counselor or psychiatrist or psychologist. They are intake personnel, for example. During the initial questions, the person should be asking, who do you prefer to work with? There are Hispanic and Latino people who do not prefer to work with Latinos or Hispanics. They prefer to work with Americans or African Americans. That is their desire, and that is what their right they have. There are people who prefer to talk about difficult things in Spanish or in their native language, in their first language. And there are people who prefer another language, and other people who switch between one language and the other. All of that is the person's preference. And there are people who prefer to work with a person of the same gender. There are people who prefer to work with a person from the same culture. And it is important that these questions be asked at the beginning, and that we should try as much as possible to accommodate and to connect a person with his or her preference. If that's not possible, because we understand that not all agencies have a diverse staff, it is important to inform the client that they decide if they want to continue or not. If they want to continue, okay. If not, then we must have a list where we can make referrals. Because here the goal is for the person to improve. The goal is not that our people have more clients and can do all the billing to get more money. The goal is that the person improves. I understand the money factor, the money aspect, because we need money to get the job done. But the primary factor must be who is the best person or agency to help this person according to their needs and what they are asking for. Remember that there are many people who, when asked the question, do not know how to answer it. Then we must explain what we are trying to ask. Imagine if someone, let's say the trauma was related to sexual abuse, and it is a woman, and the sexual abuser was a man. Then possibly that woman would say, no, I want to work with a woman, or a woman who is lesbian or wants to work with someone who is gay. That is their right, and we should ask the question and connect the person with that resource whenever possible. Next question, what can I do with the elderly so they feel more comfortable with me or with older adults because I look younger than I am? That important culture element again in relation to age, where the adults of the family see themselves as the authority. I think, and today I am not so young, but when I was young, I had to work with people much older than me. Demonstrating someone who understands cultural elements in relation to communication is extremely important. Communication is speech, how people are spoken to. There are people who are older that we should treat more formally, and we should use language like usted, Mr., Mrs., and sir, madam, not like tu or you, or simply their first name. Or when you say, for example, be careful, usted tenga cuidado, or Mr. Or Mrs. versus you take care. That terminology we use is extremely important. There are also people who look at a person who is young and may think, what can this person offer me? Because I'm much older than this person. They can't offer me anything. It is to recognize that the person may be younger, but that she or he also has credentials, knowledge, that they went to university and so on. Recognizing it will open the door to a slightly closer conversation. How you address the person and recognize him in how you recognize them. And also the question of communication includes how people look at someone. I have worked with older people and sometimes they are not looking me straight in the eye. They don't make eye contact. And for many people in the United States, that means they are not paying attention or maybe they are disrespectful. But for many people, not looking at each other's eyes is paying attention. It is a showing of respect. It is the opposite of what we are traditionally imposed to hear. And all of that is within that counseling or group session. Finally, I would say that if the person says to me, hey, I want to work with a person who is closer to my age, that is his right or her right. And I don't say, no, you have to work with me, like it or not, because that won't work. We should start asking, who do you want to work with? Then, if that's possible, connect them to a person who is older, if that's the case. But understanding the cultural elements will help with that, the development of trust and experience. That kind of experience is going to give the opening to make the person feel a little more comfortable. It has happened to me that there were people older than me who said to me, look, I thought of you this way when I saw you were much younger. And I gave you the opportunity because of the way you introduce yourself, the way you articulated things and so on. And then it helped me build trust with you. And now I don't want to work with a person that is my age. I want to work with you because you are young. But that also exists in the other direction. There are young people who prefer to work with young people that their communication style and expressions are much different, that they incorporate technology like texting in their communication and to speak in a very different way to how we communicate with older adults. And we must understand that cultural competence, because that is changing rapidly with the use of technology. And although the question was not all about it, it was about relationships and communication, we should always include the aspect of technology. So this was the last question, and I want to invite you to stay connected with NALBA. You have the website there in your screen. It is an organization that is working specifically on these issues, the policy of how we are going to serve the Latino communities. And this training center that Maxine Ruth and Dr. Mancini are running, and also the sister center, which is the PTTC, one of the goals is to increase not only the level, but the quality of the Hispanic workforce that speaks Spanish, that are trained in Spanish and continue serving our community in the way it should be served. So we appreciate and we thank Dr. Hernandez and his contribution with this presentation. And here is his contact information. And now the last thing is the satisfaction evaluation. So please wait for the link and complete this brief satisfaction evaluation. Again, that's very important so that the ATTC and PTTC can continue developing these resources and this work for the Latino and Hispanic families. Thanks again for joining this webinar, providing informed trauma care in a culturally appropriate manner. Thank you and have a great day.